Hello, thank you for joining us. We'll get started in just a few minutes. Hello, thank you for joining us. We'll get started in just a few minutes. Hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for one contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. The planning committee members and speaker have disclosed no relevant financial relationships. To receive a contact hour for this NCPD session, participants are required to attend the webinar and log into our learning management system to complete an evaluation form. Information on how to access this will be emailed to all attendees approximately 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, if we have time, we will have a question and answer session. You'll see on your Zoom webinar control panel that you can send a message through the Q&A feature. This is where you can type in any question you'd like to pose to the presenter. Be sure to hit send so the message makes it to us. Please use the Q&A feature for questions for our presenter and the chat feature to interact with other participants. We'd like to thank our speaker for sharing her expertise with us today. Our speaker today is Dr. Donna Wilson. Donna is a registered nurse who has just retired after 35 years as a full-time tenured position as a professor at the University of Alberta in Edmonton, Canada. She has worked as a researcher, media commentator, staff nurse, and nurse manager in large and small hospitals, as well as nursing homes. Her longstanding program of research and policy work is focused on health services and health policy, primarily in relation to aging, ageism, and end-of-life care, including bereavement and death hastening. Much of her work is oriented to myth busting to eliminate ageism and ensuring effective and accessible healthcare services for older and younger people. Her investigations often involve population data and mixed method research for both qualitative and quantitative understandings. She has over 400 published articles, books, book chapters, and other communications and print. We are so grateful to have you, Donna, and we welcome you. We'll turn it over to you.
Thank you. I'm really delighted to give this talk, and I understand there's nurses from around the world, and how exciting to think that we can come together and discuss this topic. I imagine some of the people that are listening in today and hopefully asking questions and making comments that, I'm hoping again that there's a wide variety of thoughts about MAiD or hastened dying. I imagine there's some nurses out there who are very uncomfortable about this, even thinking about this. Others that are fully in support of people having the choice to end their life early. And maybe a lot of people who are sitting in the middle because it's not permitted in your country. Maybe you've never, had anyone say to you they wish that, that their end would come sooner than later. And perhaps you've never even had the question of, would you help me? I want to die now. So it's a really controversial subject in some ways, and I recognize that we're probably not all on the same page. But where nurses are firmly together, I think around the world, is the fact that we really do care about dying people who are suffering, and that unites all of us. Just before I go on and get into the talk, I just want to thank Sigma for recognizing this as something that is really important for nurses to think about and talk about and explore. So thanks to Megan and Linda. Let me see now. Oh, sorry, there's a little bit of a delay in the click. So, okay, so the plan for today, if you don't mind a very brief introduction, what really got this started was on June 6th, 6 years ago, 2016, Canada's federal government passed legislation, which was Bill C-14, and that allowed eligible Canadian adults, that's people aged 18 above, that they could request and receive and gain very deliberately help medical assistance in dying. And so we say MAiD. Previously, just a little bit more than a year prior to that, the Supreme Court in Canada had ruled on a case, and it was Carter v. Canada. I'll talk a little bit more about this later on. And that Supreme Court of Canada, so the top lawyers, legal advisors in Canada, determined that dying people who were in essence disabled had a constitutional right to receive help to end their life early. In other words, get hastened death. And believe it or not, and I'll talk a little more about this, it hinged on the fact that adults certainly who are capable and not disabled can commit suicide, can end their life early. But a dying person, typically because they are not well, maybe very disabled towards the last days of life, they need help. They cannot end their life on their own. So that's something I wanted to put out there right away because it really frames in some ways what happened in Canada, how this came about, and why MAiD has become a healthcare service that nurses are involved in. Now, Canada, of course, isn't dissimilar. There are 11 countries or 10 countries around the world, 11 states, where some form of assisted dying is permissible. But this MAiD legislation and the practice of MAiD has really put Canada at the forefront of a possible worldwide assisted death movement. And certainly we're seeing more and more countries that are discussing this openly. And of course, we've just had Australia start some form of assisted death process just in the last year. So we're really starting to see more and more countries, if not debating this and discussing and turning this down, or in fact enabling this. So what I want to highlight in this talk is why this law was passed in Canada, how MAiD is actually done in Canada, and some related outcomes and developments in Canada because of the specific law that was designed. And by the way, it took a great deal of effort to craft this specific legislation and all the regulations, and then some developments after that, some changes to the law after that. So there we go. So in a snapshot, Canada is quite unique in that medical assistance in dying, or MAiD, has been approved and publicly funded. healthcare service since 2016. And again, but with some really interesting outcomes and major developments to note. One of which is that nurse practitioners can practice MAiD. They can be the ones who provide the fatal medications to end a person's life. Nurse practitioners and physicians also are the ones who can assess people who've requested MAiD. And so, as far as I know, Canada is the only country where nurse practitioners can actually be that directly involved in death hastening. And you may be quite surprised to know or interested to know that actually the Canadian Nurses Association lobbied the federal government to make sure that nurse practitioners could be directly involved in MAiD, that they could assess the MAiD candidates and also actually directly provide and independently provide MAiD. I think there's lots of different aspects of MAiD and end-of-life care that are of our interest to nurses, including some major controversies and fears. And believe me, there have been some major concerns raised in Canada, particularly by groups that indicate that they feel that they are disabled. And the chief one typically is about the slippery slope. And that's what it's commonly called worldwide. And the slippery slope is kind of two key points about it. One is that the idea that more and more and more people will get MAiD because they're encouraged to do it. Maybe they are forced to ask for it. Think of, the sort of, tired family member who's been caring for someone for a long time. And, the feeling that it's maybe not directly forced to ask for MAiD, but might feel that this, the dying person may feel that this is better for their family members who are tiring out looking after them. But also the slippery slope kind of includes the idea that, that we're really just have lax or inadequate assessment and approval processes. So anybody applies can have it, and, without much, assessment or concern, really taking into consideration, why is this person having it? Are they appropriate candidates? And all those other things that need to be considered according to our law and procedures. Now, just to let you know, in Canada, we, at the beginning of all presentations, we acknowledge that there are many First Nations, Métis, and Inuit who have lived in and cared for these lands for generations. And I'm very grateful for the traditional knowledge keepers and elders who are with us today and who have gone before us. And Canada, as you know, is a very, very big country with only 39 million people, most clustered around the border with the United States. And I'm in Edmonton, which is in the west, and in the blue province. Now, some of you maybe have been to Canada or know that Canada, has some distinct aspects. Some of you maybe have gone to Banff. If you look at the mountain, a beautiful mountain picture there. Some of you maybe have come to West Edmonton Mall, which is one of the biggest indoor malls in the world, where they have a life-size ship in a pond there, which was a replica of the ship that Christopher Columbus sailed across the ocean and discovered North America. Some of you have maybe gone to the Calgary Stampede. And certainly what Canada is known for, if you look at the two, opposite pictures in the right corner and bottom, is snow. So we have wild horses and other animals that live year round despite the snow, and live very well. And of course, we have snow, and we need snow shovels in most parts of Canada. So let's get into Canada. Why was this a federal act? Well, it's because of Canada's Constitutional Act, starting out, which was 1867, which sort of set up Canada as it is today, divided powers and responsibility between the federal government and the provincial or territorial governments. And interestingly enough, in those days when most healthcare was done at home, and there was not the promise of healthcare that we certainly have today in hospitals and clinics and what have you. Healthcare became a provincial matter, but federal government did retain concerns about health, not necessarily healthcare. And there's 13 provinces or territories in Canada, each one that has its own healthcare system, which is quite similar to all others, but not identical. Why it's similar is because in 1984, the Canada Health Act, a federal act, was passed, and that followed and built on a 1966 federal act, and that was called the Medical Care Act. And that's why we say Canada has a Medicare system. And what we have in essence is a publicly funded healthcare system, which provides universal access to all people in Canada for medically necessary care. Now, the 2016 Medicare Act and the regulations enable MAiD across Canada. For this federal act, it was done federally to make sure that every person in every province could consider and apply for MAiD, be assessed for MAiD, receive MAiD, and collect data, and that every province then would submit data. So the federal government and any other group could monitor MAiD provisions and requests and the provision. So let's get into the specifics, though, a little bit more, like why in heaven's name did MAiD happen? And I still shake my head because I started doing research about 30 years before. One of the surveys that I did, I asked Canadians, where would you like to die? And most of them said they wanted to die at home. Had they ever looked after anyone who was dying? No. And asked a few other questions. And believe it or not, 95% of the adults said that they wished that assisted suicide was legal. I followed up with a qualitative study, and people that I talked to said, you know, I have a pet or a dog or a cat that I love dearly, but began to suffer, old and suffer, had cancer, and I could go and have a humane ending for that animal. But my poor dear sister, who begged for death because of serious suffering, could not have it, and that is just not right. But interestingly enough, 30 years ago, that research study could have led to me being asked by the police to try and disclose people who were in favor of something that at that point was illegal to do in Canada. And people who did mercy killing were actually charged and put in jail for that. So that's kind of my orientation, but really, I suppose in your country and mine, there are cases that are called mercy killing that hit the news. They're definitely discussed. People sometimes can feel very sad over them, or very much in favor, or very disturbed by the fact that mercy killings do happen. But really, what they've done, I think, in Canada is that they raised both public awareness and healthcare nurse professional awareness that end of life suffering can be substantial. And I think many nurses also have cared for died people and really saw that suffering did occur. Canada joined other countries in what was really a worldwide compassionate end of life care movement. When palliative care really was started off by a nurse who became a doctor, Cicely Saunders in the United Kingdom. The first palliative care units, before hospices or anything started up, the first palliative care units were opened up in 1974 in select hospitals around Canada. These were Catholic hospitals. And most Catholic hospitals today in Canada do not allow MAiD to be done within the hospital. So we're looking at some again, some of the controversies around MAiD. But two other major things were really of historical importance when you look at why MAiD was passed and why it's being done in Canada. And that is in 1993, Sue Rodriguez, a young woman who had a young child, divorced woman, worked as a legal assistant. She was diagnosed with ALS. And she requested first to the BC court system and then to the Supreme Court of Canada for legal help to end her life early. Now, her request to the Supreme Court of Canada was nearly successful. 4 out of the 9 judges were in support of changing the criminal code. which at that point prohibited anyone from helping in any way or supporting someone to end their life early. And in 1972, actually, the criminal code was changed because people who had failed to commit suicide, who had independently tried to end their life early, could actually be arrested and jailed. So so quite an interesting kind of legal background. But it took another major legal case, and that was in 2015, when Carter v. Canada case came to the Supreme Court of Canada again. So the second major case. Kay Carter was 89, lived in British Columbia, suffered from very advanced spinal stenosis, very disabled, very much in pain, very aware that nothing more could be done to help her. And she went to Switzerland. Many people in Canada who are very desiring death hastening or MAiD were going to Switzerland, where after quite a lengthy process, they could have it approved and have it carried out there. Now, she actually went to Switzerland in 2010. It was done there. Her life was ended. And the big thing was that her family was at her side. She needed help to get to Switzerland. And of course, they came back. They could have been arrested when they got home. In fact, they were initially charged, and the charges were dropped because she had carefully documented that she wanted MAiD. It was legally done there. And I think also at that time, there was really a sea change in Canada, that people were recognizing that, should this really be a criminal act? Should this really be something, or is it mercy killing that should be approved? So on February 6th of 2015, the criminal code was determined to be contrary to Canada's Charter of Rights and Freedoms, which is that people have really the right to end their life, and sometimes they need help to end it early. Now, after that 2015 Supreme Court ruling, the government of Canada was given 12 months. It took a few extra months to develop a plan on how MAiD could be safely or appropriately done. And in June of 2016, it was set up so that adults could complete a form. These adults, though, had to be suffering from what was identified as a grievous and irremediable, in other words, incurable health condition. And at that point, it was sort of generally considered that you're seen as being the last 6 months of life, that death was definitely going to be coming. When it was set up, and it's still today, you have to have an assessment after you've filled out the form. You have to have a personal and a health assessment done by 2 healthcare providers to number one, determine that they really do want MAiD. They're not being forced into it. And that, in fact, that they are close to death, that they have a grievous and irremediable health condition. And those assessors had to be appropriate physicians or nurse practitioners, people who really would be capable of determining whether, in fact, these are people who are suffering from an incurable illness, that in fact they are wanting to have it done, that they understand what they're asking for. And also, no nurses or nurse practitioners are forced to do this work, just as no nurses or physicians or nurse practitioners in Canada are forced to actually perform MAiD. These are people who are at least open to it. Once approved, and if approved, the person can choose to either get a fatal cocktail of medications to take home and take on their own, as is commonly done across the United States and a few other countries, but mostly the US, or they could have MAiD provided to them at some location. Typically, it's at the home, or it could be any other place. And in fact, 95% of the people to date in Canada who have requested and received MAiD have had MAiD provided to them by a nurse practitioner or physician. At that time and today, the MAiD provider, no matter where they are, whether it's home or hospital or a nursing home or jail or wherever it happens to be, They must ensure that the person really is near death and that they approve the administration of IV medication before any such administration is done. This requirement, though, the stipulation led to the First Amendment of the MAiD Act. And so let me jump into that. The one major change since then, since it was first set up. And if you want to read up on this, it's the Federal Bill C7, which is called an Act to Amend the Criminal Code, Medical Assistance in Dying, that was passed and came into force in March 17 of 2021. This change was actually called the Parker Amendment, or Audrey's Amendment. Audrey Parker, who's now deceased, who was 57 years old. She was very public about the fact that she was dying of breast cancer. She'd had all the treatment she requested. And her concern was that she would have to have MAiD earlier than normal or optimal, because she was afraid that because of her brain metastases, that she would not be awake and alert at the time that the MAiD assessor would come and say, do you want to have MAiD done? And so she had MAiD early. She was very concerned about that. So the C7 revisions to the original MAiD law were primarily threefold. Number one, people did not have to wait until it was absolutely obvious that they were near death to request or receive MAiD. They did not have to be awake and alert to agree to MAiD to be provided to them at the moment that the IV drugs were going to be injected. And of course, when you think about this, one of the things that the committees, the various groups heard was that some people who had been on heavy painkillers, analgesics, stopped them so that they would be awake and alert when the MAiD provider came. And so part of the concern was that people were dying in pain, and they were dying too early. So those are the two big changes to the original law. But they also put in some new safeguards, and quite a number of them, actually. And so I'll just, in the interest of time, I'll skip over them. Now, one of the very interesting things in the future, and currently right now, is that they're trying to determine which persons with mental illnesses, diagnosed mental illnesses, can request and receive MAiD. And there's also requests going in about, can mature minors, say a 17-year-old who's maybe lived on their own, or a 15-year-old who has, been battling cancer since they were 2 or 3 or 4 or 5, can they request and receive MAiD? But also then you can kind of think about, well, what about older people who really, can't, live their lives anymore because of advanced chronic illness, or perhaps even because of dementias? And can any other people, such as maybe even tourists to Canada, can they request and receive MAiD? So in some ways, this is really policy incrementalism. You start out with something and it's, changed or inched along kind of over time. Now, something I think that has become really, really obvious about MAiD, because we have an annual report, well, we have 3 annual reports that we can look at. And also there's a great deal of attention that's been paid to MAiD in both nursing groups, medical groups, and communities, governments, etc., is that there has been no slippery slope. That was a huge fear. It still is a fear. In the last report, which was written for 2021, points out that after 5 years of legalized MAiD, in that year, 10,000 people received MAiD, which was only 3.3% of all deaths in Canada. Countries like the Netherlands and Belgium, it's about 4 and 5%, and that's been a very consistent number over time. The most recent report on MAiD as well points out again, yes, not everybody who applies gets MAiD. There were just over 12,000 written MAiD requests in 2021, and only 81% of those were approved. And they also give reasons to why it wasn't 100%. Some people request it and then they feel that's not so bad. I'm doing well. My pain is being managed. It's rallied my family, whatever the reasons are. I've decided I don't want to have MAiD, and they withdraw their request. Sometimes some people just suddenly pass away. And so MAiD, even if it was approved, will not be done. And there's other reasons, but the report is there if you want to read it. Who got MAiD? Here's where we start to see some very similar findings year after year after year. It's roughly half and half, males and females, but males for some reason tend to be a bit more. 76, around 76 is the average age. Very wide variety, 18 to 110. And females, of course, because they tend to live longer, tend to be a bit older, the ones who get MAiD. 2/3 have cancer. I think we all know cancer can be a very difficult chronic illness to live with. It's been the most common killer of Canadians for about 25 years, followed by some kind of a cardiovascular condition, a respiratory condition, a neurological condition. Those are the top ones. But 1 in 4 people who had MAiD had 2 or more conditions. One of the big concerns is that, of course, while you request MAiD because you're in terrible pain, you're not referred to a palliative care team, you don't get palliative care. And in fact, pretty well 81% each year of the people who get MAiD have been receiving palliative care, and about 4 out of 10 have been getting disability supports. I think the next thing is really what's quite critical to consider for nurses, that 86% of them or so each year um, have cited actually a loss of ability to engage in meaningful activities as being the reason why they are requesting it. Not that they have untreated cancer or cancer that will end their life. Almost as important is that they cite a loss of ability to perform activities of daily living. Now, and in fact, this most recent report also pointed out that 44% got their MAiD at home, typically with family members around them, and that's been seen as being very critical because family members can be quite divided on what they feel about MAiD and whether mom or brother or sister or grandmother or whatever should have MAiD at all. The next most common place is a hospital. Again, typically not a Catholic hospital, a palliative care facility, a hospice of some kind, a residential care facility or nursing home, and everywhere else. But I think one of the big outcomes of MAiD being the Supreme Court in telling basically the federal government they had to approve MAiD and set up a process to allow MAiD, and then the 16 months or so that the federal government needed to create what they felt was the safest and best law and procedures for MAiD, is that this opened up an enormous public dialogue about death and dying. And I think I'm talking to probably people who are very skilled in palliative care and have a background in looking after dying people and that. And oftentimes, I mean, there's a concern that it's a taboo subject. Nobody should talk about death and dying with the dying person or the family or whatever. And the research consistently shows that talking about death and dying is something that comes very late in an illness, sometimes too late, really, to arrange palliative care or to help the person get a will and a living will and all the rest of it. What happened in Canada was people talked about it a lot, and they still are. It's kind of died off a little bit. Other things, get attention, like a war in Europe and what have you. But really, what it did was it opened up a lot of family and personal discussions about death and dying. It actually helped, I think, Canada, prepare for more palliative care services, to look more openly and honestly at the fact that, yes, people do die and they probably need some help at the end of life, whether it's MAiD or something else again. So in some ways, MAiD has not been a negative social factor in Canada. Now, I want to put out 4 things. I'm kind of getting close to the end here too. So, but I think it's really important to talk about these 4 really critical, important life and death considerations. I imagine in your country, as it is in Canada, that we have population aging and also population growth. With more and more people living to be old, if not very old, we're getting more and more people 85 to 100, even older. And this is a time in life when typically there are long-term chronic and any acute illnesses or injuries, accidents, often have quite significant impacts on their personal health and well-being, and also on their families, because families, again, are the primary caregivers. Most deaths now in developed countries occur after an end-of-life process where death begins to be recognized as inevitable, both by that person who's dying or ill and those who know them, the doctors, the nurses, the family members, whatever. And it's interesting that in healthcare, we've certainly gone through about 100-year process, or even 50 years, maybe 50 years more actively, where we've tried to save everyone. We would do surgery on everyone. We would do CPR on everyone. We would do, chemotherapy on everyone with cancer, to recognizing that there is a limit to what healthcare can do and also what healthcare should do. We've really gone from a healthcare system designed to, diagnose and cure everything, to being much more balanced in looking at what is appropriate healthcare and what is it not. Another thing that we're seeing in many developed countries, if not most developed countries, is that more and more people are dying outside of hospitals, and that's being a choice made by them. And people are making many choices now, including those about how they want their life to end. That may or may not include hastened death. And of course, for the vast majority of people in Canada and other countries, it does not include hastened death, but for some in Canada, it does. So I'd like to point out that if you're interested in how MAiD came about in Canada, if you want to monitor its progress, and in fact, if you want to, identify whether you believe there's been a slippery slope or not, and, does Canada have appropriate safeguards and whatever, these were probably the 5 best places to go, articles or reports to read. And you'll notice that these are by and large government reports, although one is the Supreme Court of Canada. There are many, many authors, as you can imagine, that have written articles, and oftentimes it's their own views about whether they approve MAiD, are really concerned about MAiD, or really abhorred and really feel that that the law should be repealed and that this should not be allowed in Canada. So in some ways, if again, if you'd like to have some reading, these would be the 5 that I would recommend. And of course, there's a great amount of other reading material that you could use. So I've moved along fairly quickly because I'm looking forward to a discussion with you. And I hope that this was a useful orientation to MAiD in Canada, and in some ways more generally to the idea of hastened death. What's interesting is that most times the discussion seems to be, sort of oriented to assisted dying. We don't use the term euthanasia or assisted suicide in Canada. In most places they don't. Really what we're talking about is people who have shorter lives, and in fact death is brought on earlier. It's not assisted dying, it is assisted hastened death, that people are dying earlier. I appreciate Sigma again for enabling this presentation. Thank each one of you in the audience who took your valuable time to attend this presentation. And I certainly applaud the researchers and policy makers who did so much work to try and craft a MAiD law and the regulations, and to monitor its sense and to revise its sense. And really what we're looking, since we're nurses here today, is that wonderful 4-point or 4-step nursing process of assessing, planning, implementing, and evaluating. So I'm going to stop there and kind of open it up to a discussion, questions, comments, whatever you'd like to say. But if you'd like to get in touch with me, please send an email to me, and I'd be happy to talk with you by Zoom or by phone or back and forth by email. But I've tried to be as open and about this. I've really tried to sit on the fence by not saying I'm in favor of MAiD or hasten death. But I'm finding that again, my views are changing because I'm living in a country where it's been where it's allowed, and I'm getting older, and have had quite a few family members who passed away of different, none from MAiD, by the way. And so it's funny, how you can begin to have your own views and thoughts change about this, including my early ones, which is, my goodness, am I going to be arrested for doing research on, on assisted death? So I'll stop there. I'm looking forward to talking with you.
Donna, we have a lot of questions coming in, lots of
Okay.
discussion time. So first and foremost, of course, we want to thank you for sharing all of this great information. I think one place that we could start is, could you expound on what palliative care and palliative medicine in Canada looks like compared to hospice? Is that the same in the United States? They are two separate, but people tend to marry them together. What does that look like where you live?
Oh, thank you. What a wonderful question. And I've traveled to the United States quite a number of times to look at the wonderful developments that you've had both in palliative care and in hospice. In Canada, they basically mean one and the same. And some of that is because, as I pointed out, that palliative care in Canada really was started out by in hospitals. And most of the bigger hospitals, if not all of the bigger hospitals in Canada, will have a hospital unit with 25, 30 beds or so that's dedicated to end-of-life care, palliative care, where specialist palliative care doctors would work. We do have some palliative home care, and we, of course, have hospices where dying people will spend their last days. So it's a very blurred thing in Canada. We don't have the separation that other countries have. More generally, again, we're concerned about dying people of all kinds. And that's where MAiD kind of falls into place, is that really it doesn't matter whether you're getting palliative care or not, it's that you are requesting for whatever reason to have your life ended early.
Mm-hmm.
So I'll
Yeah.
stop there.
Yeah, thank you for that answer. I think that is perfect. And one person did say that they feel that Canada's healthcare system is ahead of the United States in terms of not trying to quote unquote save everyone, but rather recognizing that death is a normal part of uh, being human. Would you agree with that? And to what do you attribute that to?
That's a really insightful comment, and I would have to agree. For many years, I've been comparing rates of death in different countries, hospitalized death, even rates of heart surgeries, et cetera, et cetera. And Canada's healthcare system, because it's publicly funded, there's a great deal of scrutiny to the whole healthcare system, including, are we using hospitals appropriately? And and is there any reason for doing a test or admitting a person to hospital? And can we perhaps have more compassionate end-of-life care? Does it need to be in a hospital, or could the person stay in the nursing home, or could they stay at home and receive palliative home care there, or do they need to go into a hospice? So I think in some ways, because it is kind of one system used by all people in Canada, and people love their healthcare system, it tends to be the The one thing that, joins Canadians across Canada, what do you like the best? It's the Canadian healthcare system, where there's no barriers to it. I don't have to pay for healthcare. And I trust my doctors and nurses to do what's right for me. So there's a lot of trust in the healthcare system when it's publicly funded, and really it's done a pretty good job. I mean, it's not perfect, but it's done a pretty good job for meeting the healthcare needs of Canadians over time. Canada right now, of course, is trying to catch up on all the COVID delayed surgeries, and we have a lot of nurses who were, burned out by overtime and, retired early or whatever. So we're short nurses now. But yes, the Canadian healthcare system is quite different from the American healthcare system and other systems around the world.
Yes, yes, I definitely would agree with that statement. Um, you had mentioned a little bit in regards to legally competent and do we bring in MAiD too late? And so does the person need to be legally competent to make the request for MAiD? What if the end of life person has a legal a legal person acting on their behalf? What does that look like?
Oh, what a wonderful question. Yeah. When nurse practitioners or physicians assess a person who's filled out that form, one of the most important things, of course, will be is do they really understand? Are they competent in their ability to ask for MAiD? Do they really know what form they filled out? Can they give a reason for why they want to have MAiD done? So competency certainly is absolutely critical for the assessment process. And this is actually what one of the big concerns was that and why there was the amendment in 2021. The concern was that what most people, when they requested MAiD, did it so close to the time that they were dying that when they would be assessed, maybe a month, 2 weeks, a month after the form had gone in, that they had lost competencies, that they in fact were in a coma near death. So again, in the amendment, part of it was to try and encourage people, if you are going to request MAiD, do it earlier. And the second big change in that amendment in 2021 was that once it has been approved, so you've had your assessment, you've got MAiD approved, that in fact, when the person comes to your home or your hospital bed or wherever you're having it done, that in fact, you don't have to be awake and alert to say, yes, please go ahead with it. In that interim, though, between the time that you filled out a form and send it in and MAiD actually happens, the person can refuse at any point to have it done. At that point, a lawyer perhaps might be involved if there's a warring family, if you can imagine that, because what is not, although family members are part of this, obviously, family members don't make the decision. The lawyer doesn't make the decision. A lawyer only may be involved in there to protect the person's legal right to ask and receive MAiD. So I hope that was fairly clear. Again, it's a new development. We've only had that in the last year, that in fact, you don't have to be awake and alert at the very end to say, yes, I want to have this done.
Yeah, I think that that is a great response to that question. And so to coattail off of it, do you know anything about or have any information regarding expansion of MAiD in Canada to include mental health conditions?
Yes. Okay. Wonderful question. Thank you. And in fact, last night I spent quite a bit of time reading up on that, because it actually, the Supreme Court had mandated, when MAiD was first set up, that in 5 years MAiD had to be reviewed by the federal government. And there have been mentally ill people petitioning the court to say, I am suffering. It's not physical suffering like someone with cancer, but I'm really suffering from this long-term depression or whatever my diagnosed mental illness is. And so actually for the last year, the federal government not only sort of generally reviewed MAiD, but they specifically have been looking at how can MAiD be opened up so people with a diagnosis of a mental illness can request and receive MAiD. And in fact, they have been told that by March 17th of this year, they should have a new amendment to the original MAiD law and the revised 2021 MAiD law. This is really difficult, though. There have been a number of groups who, experts in end-of-life care around the world, palliative care, MAiD, etc., who cannot agree on which people with mental illness should be able to request and receive MAiD, because it's not nearly as clear that they're at the end of life. It's not nearly as clear, are they competent to ask for and understand what this MAiD form and this means. And of course, there's also the concern when you look at compassionate world and palliative care and all the rest of it is, have we done enough that people, who are living with quite a difficult mental illness, have we done enough to try and stabilize their health and give them a good life so that, out of desperation, they're not asking for MAiD. So it's a very complex issue. And I was recently on national TV where I said, well, March 17th is coming very quickly, but I think it's going to take much more time than that to come up with a safe amendment so that in fact mentally ill people can ask for and receive MAiD. It's much less cut and dried as compared to people who've had cancer diagnosed, they've had all the chemotherapy and surgery. They just don't want to spend any more time in hospital and they know they are dying. It's very different circumstances.
Mm-hmm.
So yes, at some point, we will see MAiD for mentally ill people in Canada. As I believe now, we will see it for mature minors. Those are the next two groups. But what will it look like? I really don't know at this point. It's very much up in the air. All I just know is that that incrementalism will continue and people with mental illness and mature minors at some point will be able to request and receive MAiD. I'll stop there.
I love that you were reading about it last night. I just love that. So thank you for sharing. A couple questions came in regards to people that are not citizens of Canada. Are they able to get MAiD if let's say somebody came from the United States to Canada, and what does that legal work look like? And then what would the medications look like for somebody if they wanted to pursue that route?
Oh, fabulous question. Thanks. One of the things I did over the last week, I think nurses are wonderful for preparing for talks and for work and what have you. Over the last week, I actually read the original C-14 and C-7 acts in all and the commentary about them. And in fact, from day one to now, you have to be a citizen of Canada. So we're not going to be like Switzerland, where we've opened the door for anybody to come here and fill out a form and have it done. So again, you have to be a landed resident or a citizen, like born in Canada, or you become a citizen of Canada to have it done. Now, along the second question, is about the medications. I have talked with nurse practitioners and I've looked who've provided MAiD. And I've looked up, there's a course actually that you have to take, trust nurses to make sure that nurse practitioners have a course so they'd be well prepared to safely and legally and appropriately provide MAiD. And it's a cocktail heavily based on barbiturates. And I'm giving a talk actually at a veterinary conference and talking about pet death and how terribly sad we can be when our beloved pet passes away. And I stumbled across the fact that we have a worldwide shortage of barbiturates right now. And in fact, veterinarians around the world are preparing to euthanize pets without using barbiturates. Um, so again, typically it's a cocktail. And it's interesting that Canada set it up where, like the United States, where you can get a prescription for this cocktail, go to a pharmacist, a drugstore, and take this cocktail home. But there was a great deal of concern about the fact that the person could take that cocktail alone, and in fact wake up a few hours later, perhaps if they had vomited the pills. And so this is why 99.9 to 100% of times it's an IV injection by a nurse practitioner or physician. And that's why it's typically kind of chosen that way, that people who've requested MAiD want to make sure it works. So I don't want to take the chance of taking these fatal drug cocktail home, and the risk that maybe my grandchildren could accidentally take them, or I could take them and find out I wake up that in fact it hasn't ended my life. So again, long answer, but it's a cocktail, but it's heavily based on barbiturates. And I'll stop there.
So, Dr. Wilson, I'm not sure that we're going to get to all of the questions. So just a reminder that if you want to continue to connect with Dr. Wilson, please use the email address on the screen. I know that she is more than willing to dialogue with you if we don't get to your question. One question that I do want to touch on before we end today is how does MAiD affect those who have young children, but they are requesting this service? Have you experienced that?
Wonderful question. And this is kind of why I put up that, that the average age is is 60 or 70, that in fact, typically it's not people who are requesting this that would have young children. More likely they would have grandchildren. And in fact, maybe even adult grandchildren. All of the nurse practitioners that I've talked to that have been involved in MAiD or in assessing MAiD, typically, again, it's 50-year-olds, 60-year-olds, 70-year-olds, occasionally 80-year-olds who've, really had cancer for 10, 20 years. They've had ALS, they've had heart failure, respiratory failure, for a number of years. So again, it typically doesn't involve young children. There, of course, there is definitely the option, though. You can be 18 years old and request and receive MAiD. So, of course, there could be young mothers and fathers who are requesting this. I would imagine that in these cases, there'd be much more care about where MAiD is being done and who's there at the deathbed. That the nurse practitioner, if it's a nurse practitioner or physician who is doing this, that in fact they spend some time comforting the children and the people that are there in the room. It's not something you just walk in and 5 minutes later you walk out of the room, that if you're the provider of MAiD. And this is one reason why there's quite a number of nurses and doctors who just don't feel prepared to do MAiD. That this is something that you have to really believe in. And you have to really know that you're going to do it carefully and well for that person and their family. So, in some ways, I've been very heartened by talking to the nurse practitioners that, I mean, these are people who really, really care about dying people and recognize they have a legal right in Canada to request MAiD and to have MAiD if they're assessed as appropriate for it.
So it looks like we have 2 minutes. Any parting words for us today, Dr. Wilson, before I close us out?
Well, first again, thanks to Sigma. I'm thrilled to talk with nurses around the world. Nurses do such important work, and sometimes it's kind of unrecognized. But nurses do such amazing, caring work. I'm not surprised that there would be interest around the world about hastening death in Canada, MAiD. And I think again, what brings us all together, even if we don't agree with MAiD, we may think it's too often done, or it should never be done, or we think it should be expanded and made more easy. I think the fact that what brings nurses together again is we really do care about our patients, and we really do care about health and helping keep people from being suffering. And I'm glad that we had this discussion, and thanks again, Sigma, and specifically Linda and Megan for facilitating today.
Yes, of course. And of course, we want to thank you for all of this great information. The feedback has been wonderful, and everyone is so thankful that you took time to share with us today. And we look forward to hearing more from you in the future. We hope
Thank
that
you.
you enjoyed our webinar, and as a reminder, 1 week from today, you will receive an email with the link to the evaluation for you to obtain your Nursing Continuing Professional Development Contact Hour certificate. Be sure to check out Sigma's upcoming webinars, podcasts, and resources for you and your colleagues at sigmanursing.org. Also, previously recorded webinars are freely available on the Sigma repository. Thank you for joining us and have a wonderful day.
Thank you.